knowledge sharing series. I am Dr. Gayatri Gadyok, your host and moderator today. A little bit about myself. I did my MBBS from Christian Medical College, Ludhiana, and MD from the Maulana Azad Medical College, New Delhi. I worked in histopathology and hematology for more than 30 years and then switched to hospital management as part of the founding team and medical director for Fortis La Farm, Delhi, the first comprehensive facility for women's healthcare in the country. I then joined the WHO, where my focus was on public health, program development, and quality assurance in the Asia Pacific region. I came back to India and joined Nova EV Fertility as the Director Operations, where I established and operationalized 5 IVF centers across India. A few years ago, as a World Health Organization consultant, I joined hands with the Ministry of Health in Kerala to establish systems for quality blood transfusion services. In addition to healthcare, I'm also the chairperson of a non-profit NGO called Rohini Gadyok Foundation that works in the field of education, providing for underprivileged children. Given my work and areas of interest, I'm particularly pleased to be collaborating with health travelers worldwide and healthcare professionals to discuss relevant issues that we are faced with at this time. The objective of the knowledge sharing series is to bring credible medical information to the public at large through enriching conversations with renowned experts from across the world. Health Travelers Worldwide is an NABH accredited health advisory firm that helps critically ill patients seeking quality healthcare services. It works independently to provide prospective patients with personalized advice and support through its dedicated medical advisors. Over the years, it has built the highest level of trust and confidence amongst its more than 7,000 patients. Besides, working with some of the top insurance companies, ministries of health, and international NGOs. I have the pleasure and privilege to introduce today's speaker, a close friend and admired colleague, Dr. Sonia Malik, Director, Southend Fertility and IVF Centers in Delhi and NCR. Dr. Malik has had an excellent professional and clinical track record. She has been Chair, Infertility Committee FOXY, President, Indian Fertility Society, and President, Indian Menopause Society. She was on the editorial board of the Journal of Reproductive Health and Medicine and the Journal of Fertility Science and Research. She has been a scientific collaborator at the Reproductive Research Center, Cleveland Clinic, USA, and member of the ICMR Task Force on Genital Tuberculosis. Dr. Malik has been honored by the Indian Medical Association and received several national and state awards. Please ask any questions you may have on the subject and share them with us in the comment section. We will try and take as many as possible. Dr. Malik, welcome to the show.
Thank you, Dr. Gayatri. Thank you very much. It's indeed a great pleasure to be back here with you again. As you mentioned, we are close friends and also have been colleagues working together in various hospitals. So it's really a pleasure to have get this opportunity to be with you today. And you as my host on this chat show.
So this week's session on understanding fertility and treatment options is very, very timely. Many couples may have been planning a family, and some may have already started their IVF cycles, and then the coronavirus pandemic hit us. I'm sure there are many questions that they will have related to this. So what I was planning, that I'm going to divide this session into 2 parts. The first will be related to the challenges couples are facing with infertility and treatment options during this time. But then I would also like for you to dedicate some time to understanding the important issue of male infertility, because although it is common, it remains a taboo and is much less discussed than female infertility. Now, WHO data shows that infertility affects 1 in every 6 couples who are trying to conceive, and an infertility diagnosis is never easy. So, can you tell us, when should a couple start to think about seeing a doctor and going in for assisted reproduction?
Thank you, Gayatri. That's a relevant question. And I think WHO also defines infertility as a state being where a couple has been trying to get pregnant for the last 1 year and they are unable to conceive for whatever reasons. So that is basically, and some years ago, there was a distinction made between fertility, infertility, and sterility.
Right.
Sterility while infertility is a relative state where the patient can conceive with help. Sterility is a condition where patient is not able to conceive at all with her own self, and even maybe with assisted reproduction. So the next thing that you asked, yes, the alarming levels of fertility are there across the world, and India is not far behind. Even though we are a populous country, but we have whopping numbers of infertile couples as well. And then my answer to your question as to when they should seek assisted reproduction or assistance, not assisted reproduction in the literal sense, but assistance is,
Right.
it depends upon the age of the patient, age of the couple. Suppose you have a young girl who's got married, say 22 years old or 23 years old. She still has a lot of time for her to get pregnant. She's young, but and so she can wait even if 1 year has passed and she's not in a hurry. But if you have a 38-year-old or a 36-year-old woman or lady who's now planning or has just now got married, recently married, then she really doesn't have much time. She needs to hurry up. So she
Right.
needs
Right.
to seek assistance quickly, as fast as possible. The other one can take some time, but of course, as we go ahead with with our conversation, we'll be more clear on what I'm trying to tell you as regards to age of the couple. Yeah,
Right. Well, the biological clock is running out and all those
that's
things
right.
we read
That's right.
about. But, in this country, it is a little ironic because when you talk about infertility with our booming population, so people then question what is the need, you know, for someone. I mean, the fertility levels are obviously high
Right.
because of the population that we have in this country. So, what has happened now in the last couple of years, where now there's a huge demand for infertility centers, for doctors who are specialized in infertility, and there's so many patients going there. So, what has changed? What has changed the dynamics?
Yeah, of course, like you've very well pointed out, and I also said that we are a populous country, and
Hmm.
therefore we do not need more, as we would say in terms of relative numbers as far as the country is concerned. But reproduction is a very personal thing, and it
Right,
is the
right,
need. It is the need of an individual. It is not the need of a nation. It's the need of an individual, a couple, a family. Therefore, it becomes very important for each couple or each person who, well, you have people now who are not even married, but they still want to have children. So it is entirely your own personal need to reproduce which drives you to an infertility or a fertility specialist.
so
And
it's a
then,
choice. It's a choice that
it's a
they would
personal
like
choice.
to
It's a
exercise. Yes.
yes, yes.
Right, right.
Personal choice depending upon the dynamics of the society, depending upon what is going around them. You see, in our country, as you rightly said, it's a social taboo to be infertile. They are. I'm not talking about the urban. We are basically in the Delhi NCR. We are dealing with the urban population mainly. But then, if you look at the rural population, they have their own problems and they have their own kind of taboos over there, which are much more than what we have in the urban class. But
Right,
like
right.
I said, whether it is an educated woman or whether it is an uneducated woman, everybody wants to have their own child. And even for that matter, men. I've seen so many men who are also very, very concerned about not being able to conceive. So it's not that it's only the women, it's also the men. And
Right.
then, like we said, uh, despite being a populous country, there have been changes in the country which have led to the fertility going down, even in India. We
Right.
know
Yeah.
that from the statistics now that the fertility is declining, and that is basically because of various environmental factors. And
Protocols.
mainly, yes, we have the lifestyle changes that we find in the urban class. Most importantly, our women are getting better education, and therefore they are marrying late. They are starting with all this late. That is one factor. Then, because of their lifestyle, they don't exercise enough. Obesity is tremendously on the rise, we know. And as an offshoot of obesity, we also find that diabetes is also on the rise. We are a diabetic capital of the world now. And so also you have these environmental toxins in the air in terms of pollution, air pollutants, water pollutants. And therefore, and food, majorly food, we are not eating not only the right kind of food, the food is full of pesticides and fertilizers. And
Right,
that is
right,
one of the major factors in the rural population as well for an increasing rise of infertility. The fertilizer use and the rampant use of pesticides. Along with that, in the rural population, there is a huge number of patients who are suffering from infections. I'm not
right.
saying it's not prevalent in the rural, in the urban population. It is also because of increased promiscuity in the urban class. We are finding a different kind of infections in the urban girls, whereas in the rural belt, it is mainly because of unhygienic conditions that we find infections on the rise. So all
Right.
these factors combined together, they are leading to infertility. As we started this chat, you mentioned about male infertility. So just one little thing about the causes here, the changing causes of male infertility also. Let me touch upon that. And again, the same things hold true for that. It's the environment and the lifestyle. The boys don't get any time to exercise. They are just sitting these days, especially with the corona. We are all sitting at home on our laptops, like you and me just now, and doing only visual talks. Even for their work, they are all working from home. So it's a rampant use of cell phones as well as these laptops, which are also known to cause problems for the men.
Yeah.
So therefore, all these factors put together definitely are indicating that there is a rise in infertility in the country.
Infertility.
Yes.
So now what's happening in this? Let's come back to the corona. The pandemic has hit us. First, we were in lockdown for 2 months. Now, you have other issues like social distancing and what have you, and with the numbers going up. So, what are your recommendations for patients who are thinking of starting IVF treatment now? Should they wait? Should they start now? Because the concern is that whether, suppose one of them gets infected, so would that impact either of them during the course of the treatment, the result of the treatment? I know it's early days yet, so I don't know if you have any data on this, but what would be your advice to couples?
Yeah, that's absolutely pertinent at the moment. We need to understand this disease, try and understand it. Like you said, there's very little data on it. But whatever data has emerged from China and from the Italy, from these two countries, it tells us that let us talk about the gametes. They haven't
Okay.
found any receptors. And I think we would like to inform the audience also that the virus is actually entering the body. It latches on to certain points on every cell, which are called the receptors. And they must have read, everybody is reading so much about the ACE2 receptors now. So those receptors on which the virus latches on are not present on the egg. They are not found
Okay.
there. Okay.
Okay.
There is, in one report from China, they did discover the RNA of the virus in the sperm, but in the semen. But the actual virus was not found in any of the sperm samples. So, but then yes, since there was the RNA, it may have been there. Therefore, we are becoming a little more cautious of the sperm rather than the egg. And then when we come to the fusion and we talk about the embryo, again, the studies have shown whatever is available, that up to the third day of development of the embryo, the virus does not affect it, but because
Okay.
it doesn't have any receptors. Again, on the fifth day, or the blastocyst, many of our viewers may be knowing what a blastocyst is, because this has become a very fashionable word these days. I want to have a blastocyst transfer. So if the embryo develops up till the fifth day, then these receptors grow on it. So they have found the ACE2 receptors on blastocysts. Therefore, we are not advising transfers of day 5. We are transferring day 3. And even if we
Okay.
are freezing the embryos, we are freezing day 3 embryos. So having said this about reproduction, I come back to, should we be starting or not? As far as therefore the safety of the procedure is concerned, it's quite safe until and unless you are really infected, and then there may be a problem. So what all of us across the world, the guidelines have suggested opening up now Even in India, our own guidelines, I was a part of the task force to form the recommendations for starting the IVF practice in India. And we have also suggested that we should open up now and
Okay.
screen the patients when we take them up for say an IUI cycle or an IVF cycle. As soon as we are going to begin, we screen them for the disease. If it
So
is
screen
present,
both.
we cancel. Yeah,
So
that's right.
screen both the partners.
Both
Both.
the partners,
Right.
and then if it is present, we just say no. If it is not there, then we take them through, and before we do the procedure, 48 hours before that, we screen them again, because there's a period of 10 days in between, and she may have got the
Okay.
infection again, or he may have got the infection. It does mean an extra cost to the patient, because we know that the test is expensive, but then safety is much more important than cost. Therefore,
Yeah.
this screening is mandatory.
Better to be safe than sorry. Yes.
That's right.
Yes.
That's right. This is mandatory, and therefore we do it. So
Okay.
that is one. And then the other issue is, should we not be doing it at all? Why I feel that we should be doing it. This is a personal thing. It's not written in the recommendations, but over a period of time, Gayatri, you're a pathologist, and you would also understand. In the past, whenever we had patients with viral diseases, we always told them not to conceive for a specific period of time. Say if it
Right.
was German measles, we tell them no. 3 months, no, not at all. Now, in this particular virus, we do not know what is the effect going to be on the organogenesis of the baby once the
Yeah.
patient conceives, right? And that I say not only for the IVF patients, but also for the normal pregnancies that people might be planning at this time. If they are infected, underlined, if they are not infected, there is no risk. But if they are infected and if they are planning a pregnancy, then yes, there is a risk. There may be a risk. We never know. There are no studies,
Right.
no data on that, right?
So it's still
So,
early days yet, because we still don't know the effects of coronavirus in
that's right.
pregnancy,
That's
right?
right.
So
No. So my take on that is that if you are planning some kind of a fertility treatment, it is better to do it now when you are not infected. Suppose
okay,
tomorrow, if you are, you don't know how long you'll have to wait till the effects go away and when you are absolutely safe to go through it. So that
right.
is my take on it. I do not know, because I don't have confirmed data on it. But yes,
Mhm.
from whatever we have of the earlier viruses, this is what we can sort of think about, isn't it?
So it is relatively safe even
Yes.
now,
Yes.
despite the pandemic, if the couple both, if they test negative,
Negative.
you
Yes.
know, before they start the treatment, that's
Yes.
relatively safe to go ahead with this
Yes.
procedure. Okay. So you said that. So I was going to ask you if the coronavirus infection influences embryo implantation. You said something about day 3 and day 5.
Yes.
So can you just elaborate a little bit for people who are listening in?
So, implantation is the process in layman's term where the embryo latch, or the so-called baby latches onto the mother's uterus. Okay, and then it sort of invades the linings of the uterus and buries inside the uterus. That is called
Right.
implantation, right? And so the factors, therefore, are the embryo itself and the uterus. These are the two factors which are responsible for implantation. We talked about the embryo, saying that day 3 embryo is absolutely safe, and day 5 may relatively be a little more risky because there are receptors. And if the mother is infected, then, or the environment is infected, suppose the lab is infected, then yes, there may be a chance of transmitting the infection. But suppose the embryo is absolutely normal and the mother is infected. In the uterus, there are one or two reports, one maybe, where they are suspecting that there may be some changes found in the uterus. But as of now, there is really nothing which suggests that you cannot go through an IVF. That is why we are the first thing to open up was frozen embryo transfers, because the uterus is absolutely normal. There is nothing in it.
Mhm.
We don't find any receptors over there. So therefore,
Okay.
the chances are that there is nothing.
Right.
So that
So
that is why implantation is all right. Fine.
okay. So talking about frozen embryos, so some couples get their embryos frozen because a cycle could not have what was probably cancelled or postponed. So is there any difference in the success rates using frozen versus fresh embryos?
Another very very good question, Gayatri. These are doubts which need to be clarified.
Yeah, yeah.
For the last 4-5 years, everybody is going gaga over frozen embryo transfer, and we also resorted to something called freeze all policy, where everything is frozen and then transferred on later.
Right.
Now with the data which has accumulated over the last 5 years, and in my own lab as well, my own personal data, it suggests that if you have a normal person who herself maybe doesn't have any problem, but she's got an IVF done because she's got a male partner problem, a male infertility, we call them normal responders. She's a normal person.
Right.
Then we have the PCO group, or the one who's producing 20 eggs, 30 eggs, something like that. The ones who are producing too many. They are called hyper responders. So these two groups of people, where you are the ones where if you freeze their eggs, you get better results. You get better results than in a normal fresh transfer. But if you have the low responders or the poor responders, are the ones that we now find a lot in the country, where they are producing just 1, 2 eggs or 3 eggs, in a cycle. So anything which is where we get less than 4 eggs, their fresh embryo transfer gives better pregnancy rate as compared to the frozen. So it definitely depends upon the type of patient that you have. So you have to be selective.
Right, right. Now there are some couples who need to, or who do, they resort to using donors. So the donor could be an egg donor or could be a sperm donor. So are there any reports that show that coronavirus may be transmitted to the recipient if the donor was a carrier or was infected?
Actually, donor cycles or third-party reproduction has not yet opened up anywhere across the world. They're all scared. The reason is that how are you going to ensure that these people are not infected? Especially because basically she may lie to you and you may not get a proper report. And so therefore there is a risk of transmission. Hence, we are not yet starting with third-party reproduction at all. Whatever is, so it might take a little while to ensure the safety of the donors before we can start doing that part.
So will this be a complete no-no, and for how long?
No, I don't think so.
Would this policy
I don't think so, because basically what is happening is you do know that there are lots of people who have been running ART banks, as we call them. These are the people who are supplying us with sperms, and they are supplying us with donors, as well as they are supplying surrogates. So this also is a part of the ART, the entire ART business, as we would call it. And therefore, they are now trying to ensure complete safety of the donors as well as the surrogates that they are providing to us. So once we are convinced that the donors that they are going to give us are safe, so if we ask them to get us a donor and we like her and we do her testing in our facility, and then we find that this one is reliable and she's free of the disease, we will take her up. And if he ensures that he's going to keep her in the hostel and not let her go anywhere, and then again, we are going to do another test just before we take her up for egg retrieval. So then, if that is also negative, then only we'll take her up for egg retrieval. Otherwise, she just goes away. So after having ensured all those points, then we shall be going ahead with this. So I think in another month or two, it should be in place. We should be able to resume doing all this. Especially,
it's a variable that is.
Yes.
It's a variable that's really not under your control. You're dependent on somebody else. Yeah. Okay. So that's the risk that you don't want to take at this time.
And, especially the surrogacy program. Now, the government had already advocated altruistic surrogacy, as you know, in the country. They were already saying that we should be resorting to that. So if a person is getting a relative, an altruistic surrogate, and he is sure that this particular person is absolutely disease-free, doesn't have corona, and there is no chance of her getting corona as well, we don't mind doing a surrogate cycle for her, because that is entirely within the policy of the country. And we know that she's disease-free. So that can be done much easier and faster.
Okay.
Yeah.
So now I think we have covered some of the general areas. So I'm now going to come to the second part of my discussion, which is male infertility. So when one thinks of infertility, the focus is always on the woman. People think it's a woman's issue, when we all know that in fact nearly 30% of the infertility can be due to male factor, in other words, the man, right? So no matter what the circumstances, women often blame themselves when struggling to conceive. I was reading I was reading an article, and I'm going to quote Dr. Marie Davidson, psychologist at the Fertility Centers of Illinois, USA. She says, quote, women feel it's their fault no matter what. Even if they don't feel like it's their fault, they want to protect their husband's feelings. She says, male factor infertility can cause conflict within couples due to coping styles. Men might not want to worry or pursue treatment until after a few months of trying, but women dealing with infertility might want to seek out treatment ASAP because they are worried their egg quality might be deteriorating the longer they wait. So, my question to you is, in your opinion, will this mindset change with today's generation, or will it remain the same?
It is already changing, Gayatri. It is
Okay.
already changing. We are. I'm quite happy to see. In my years of IVF infertility practice, in the beginning when we started in '95, we used to have the mother-in-laws come in with the girls. They used to be the people who were bringing in this so-called couple. We never used to see the boys, and then gradually it has changed, and now we see that it is the couple that is coming in for consults,
Okay.
and then they participate equally in whatever is happening to their wives, and they are very receptive. M- uh, you said, like you very rightly said, it is about 30% in the males, and out of those 30%, I would say, and if I take that as 100%, again I would say about 50 to 60% men are receptive, and they generally accept that it is a male infertility problem, and they are ready to take treatment. We do have still that the old mindset, the primitive, I would say, the kind of Indian mindset where they are not ready to accept that it is them. We do have
Yeah.
those patients as well, but that number is gradually decreasing as we find that there is more information, there is more awareness about this particular condition. So that is why
Yes.
it is very important also to talk about male infertility to groups. It's really
Yes.
important to create this
That's true.
awareness. Yeah, yeah.
That's true. So then, according to a study in the Journal of Sexual Medicine, couples struggling with male factor infertility have a quote have a lower sexual and personal quality of life, end quote, than couples for whom infertility is unexplained or is due to the woman's biology. So, do you agree with this statement?
Uh, yes, I do. And again, I would say again and no as well, because that it's a relative thing, in the sense that if they do not know that they are the cause, they are just as normal as any other couple. But
Right,
once they get to know, that stress increases, and that stress is more worrisome to the male as compared to the female. For some
right,
reason, I don't know. The female is the passive partner always in association when they are together. Therefore, it is actually he who kind of becomes the passive person then, once he gets to know that there is a problem with him. which
hmm,
is why which is why you have to be really, really very careful when you're counseling the men for something which is wrong with them.
right,
Because
right.
one, you know the psychological impact of infertility, male infertility, I feel, is much more in the men, as far as the personal relationship or the sexual relationship is concerned, as compared to the women. They take it
Yeah,
better,
yeah.
and
So,
then they become
talking
a better.
Yeah,
Yeah.
so talking about psychology, when I was involved in setting up the Nova EV fertility centers, we followed the then draft ICMR guidelines, and every center had a psychosocial
Yes.
counselor on board who was trained to address these issues.
Yes.
So, I mean, I know you also have. So, what do you think? What is your opinion? How important is it to have a counselor in a center to deal with these very issues?
Gayatri, it is, there are two reasons why they are important. One is, of course, to be able to talk to them more professionally,
Mm-hmm.
and because see, the methods that these psychologists or the counselors use is not something that the gynecologists are very aware of, and so their approach to the problem is very different from ours.
Yeah. Right.
But having said that, ultimately the patients or the couples identify themselves more with us than anyone else. So
Mm-hmm.
for any couple who goes through treatment in any center, eventually it is the treating doctor who is the biggest counselor for them. No matter what the counselor says, this happens to us as well. Whatever she may be telling them, she ultimately reports to us, and it is us who speak the language of the counselor in order to explain what actually is wrong with them. So that final thing has to come from us for them to really understand what is their problem. And we generally, 99.9%, we always agree what the counselor has told us, because yes, that is the truth. But in order to make them understand it better, that partnership between the counselor and us is very important, and we need to
Right.
speak the same language.
Right.
Otherwise our patients get very confused. So for
Mm-hmm.
any, this is my advice to all of us who are listening to this, that whenever we are talking, even you and I, Gayatri, if we don't agree on some point, then either you or me, one of us is going to be confused, isn't it? So
Right.
similarly for the patients as well, it becomes very difficult to listen to two opinions. Therefore, all of us have to understand the problem of the patient first, and then talk to them, so that we come across as the correct. And why should anybody say anything different when you have to tell them the truth, whatever
Yeah.
it
Yeah.
is.
So now we're coming to, because we're getting some technical questions. So I'm now coming to the technical part. So
Yeah, sure.
there are some standard WHO guidelines on semen analysis.
Hmm.
It's not enough for the sample to contain adequate number of sperms, right? We
Yeah.
need to know that they are functionally competent also. So how should the semen sample be examined and reported from the point of view of reproductive potential of a man?
It's
What are the
extreme.
challenges you face when you get a semen analysis
Yeah.
report?
Yeah. So this is an extremely important and very common problem that we face, Gayatri, in our day-to-day practice. What is happening is that most of the path labs that are there in the country, I don't say that any of them is I mean, they're not bad or anything. I'm not being derogatory to anybody. But what I'm trying to say is that the technicians or whoever is being trained on that is following a very different method, just reporting how many sperms are there, and that's it. But
Right.
for us, when we have to report it from the point of view of reproduction, we need to know whether there is a considerably normal kind of a picture over there or not. And therefore, WHO came out with this report in 2010, which was, the semen samples across so many countries, and then they decided what was normal and not. And so what it states is that now the count, even if it is 10 million, it's okay. The motility, the total motility has to be 40. And there is
Right.
something called as progressive motility. That means the fastest moving sperm, which is because they are the ones that are going to impregnate the oocyte. So they should be
Mhm.
about 32%, you know. And then you have the motility, the morphology or the shape of the sperm. That is where the crux is. That is where we are always faltering, because nobody is using a standard criteria for that except the IVF units, and that has that the cutoff for that is 4%. 4% is the percentile. I would not say percent; it's percentile. So if anything is below that, then it is said that this person is not going to be able to conceive on his own. That is what it states. So therefore, when we get need some help, when we get these semen samples assessed outside of the IVF labs, they do not assess the morphology at all. And if at all they are assessed, then they are assessed in terms of different standards. So when we tell the couples that their motility is bad or their morphology is bad, we are not bothered about the count. It doesn't matter to us. Anything, even if it is 1 million, we can still manage to do an assisted reproduction, as you know. So, but of course, the morphology and the motility does matter to us as well. So once there is a challenge over there, once there is a discrepancy in the report which is generated by the path lab vis-a-vis the one that is generated by us, that there is a doubt created in the mind of the couple.
Right.
For that, I would, I want to point this out that, there is a difference in the approach because of the specialization. This is a super specialist field. And therefore, the people who are examining semen samples in IVF units are definitely better than the ones who are doing it in a path lab. So that is the challenge, and that is what people have to understand. Many a
Yes.
times you get couples who've gone through multiple cycles of IUI without getting any results. And they come to us as unexplained infertility because everything is normal, the semen is normal, the egg is being formed, the tubes are normal, then what is wrong? And these patients, when we do the semen analysis, invariably we find that it is actually the semen which is not correct. And hence we have the problem.
Right, right. So what can young men do today to have a good quality sperm?
That's $1 million question, though, because many of the causes of this, the causes, 75% is unknown causes. It's only
Okay.
25% where we actually know what is the cause for this, whether it is genetic or it is an infection or it is hormonal, any of these. But the 75, the bulk of it is actually, we don't know, idiopathic. And in those patients, we are generally advising what we call as empirical treatment, where we
Mhm.
feel that it is actually the lifestyle and the environment which is the fault, which is the
So these are
reason.
the things that you spoke about earlier about the
Yes, yes,
lifestyle, the
absolutely.
factors that affect the lifestyle. Okay.
Yes. So
Right,
for
right.
in them, we must add smoking and alcohol because in
Mm.
men, the smoking is, as you know, it is known to cause so much damage to every organ in the body, and so also the semen, so also the sperm formation, or alcohol as well. Too much of alcohol or any other drugs that the boy may be taking can harm the sperm health. Then another thing which is very very common is this bodybuilding, the six pack that every boy wants to have these days. And then, therefore, those protein supplements that he's taking, which may even have some steroids in them, anabolic hormones in
Okay.
them, as you know, these also are harmful for the sperm. So, beware when they are taking any such supplements because that also is not good for sperm health. So
Yeah.
these things have to be taken care of. Yeah, yeah. Or
I think
lifestyle. Then, sorry.
that's
Yeah.
a very important thing you talked about because you young men today or young boys are very conscious of their
Yes.
physical health, and they do a lot of these, and when you go to any gym you see a lot of them just gulping down these protein
Yes. Shakes.
formulations, yeah,
Yes.
yeah, to build
The other
muscle.
thing is another thing I wanted to point out over here is obesity. Now,
Right.
again, we must understand that obesity also means that there is a lot of female hormone being formed in their body because you know that estrogen there is a lot of estrogen
Stored in
in
the fat, yes.
yes, yes, and
Mm.
also from the from the environment and from the water pollutants and what all chemicals we are getting lots of estrogen. So the estrogenization of these boys also becomes a factor where the sperm is not proper. These are
Right.
new facts which are coming up now and which we are getting more aware of. And so they have to be careful that they are not gaining fat also. It's not just the
Mhm.
protein, it's also not just the muscle mass, it's also the fat which is important. It should not have too much of they should not have too much of estrogen. And
Mhm.
one clinical feature which may tell them that this may be one of the reasons I may be affected is loss of libido. If they are obese and they have loss of libido, they should be careful. Maybe their estrogen is high as compared to their testosterone. The female hormone is more than the male hormone, which is actually leading to this problem.
Right, right. So there are various kinds of treatment options available for male infertility, which could be medical or surgical. And men, I would imagine, would be a little reluctant to opt for the surgical option. So can you please elaborate on this?
On whether they should be taking it or not, or
No,
what are the
what are
what
the
are the
surgical
options? Yeah,
options?
okay.
Yeah, 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 yeah.
These are surgery is to be done under two circumstances. One is if they have something called a varicocele, which is basically an accumulation of too many vessels around the testicles, which heats up the testes, and therefore it is detrimental to sperm formation because sperm is always healthy or good in a slightly cooler temperature of 25 degrees centigrade. Body temperature is 37 degrees centigrade. So testes is a cool organ. anything that heats it up, even if it is their profession, they have to be careful. Varicocele is therefore a surgical correction is required. That is one part. The other part is that, which is majorly now coming up, is something that we call obstructive azoospermia. Azoospermia is the term which is used when we don't find any sperm coming out in the semen. When the semen is without any sperm, we want to check why it is there, why whether this patient is not forming any sperms, or is it that the sperms are not coming out of the tract. These are the two
Mhm.
things. So if it is that the sperm is not coming out of the tract because of some kind of obstruction over there, which may be because of repeated infections like tuberculosis, like chlamydia, any such infection, which is quite common, then or in the past he's had some kind of an injury because of which the sperm is now obstructed. In such cases, you have to
Surgery
make
will help.
surgery will help. And that
Mm.
means that you have to retrieve the sperms from the testicles or from the epididymis,
Yeah.
some part of the tract. Yeah.
Yeah, you mentioned the term azoospermia, which means there is no sperm in the semen sample. Can you just, there are these terms they use: oligospermia, teratozoospermia. Can you just tell us what these mean
Yeah, yeah,
also?
sure. So oligospermia is when the count is less than normal. And like I
Mhm.
said, that we in for a normal semen sample, it is 20 million and 10 million per ml, whatever it is. And that if it is anything below that, then that is called oligo. So if you're talking in terms of count, it is oligo or normospermia. Normospermia when it is normal, oligo when it is less, and
Less than
azo is
that.
when there are nothing. Then when there is
Okay.
nothing.
Okay.
Teratospermia is when the sperms are abnormal in shape.
All right.
Okay. So when you have abnormal, like I said, the morphology needs to be normal. But if but they're all absolutely abnormal, then it is a teratospermic sample.
Hmm.
And when it is these the motility which is at fault, then we call it, then it is what is it called now? Oligospermia. Oligozoospermia.
Okay.
Oligozoospermia. Yeah, yeah.
Okay. So the
With the
motility is
motility.
less.
Yes,
So
yes.
is
With
this
the
the time? Is this the time? So when you hear of terms like ICSI and TESA and TESE. So is this dependent on the sperm morphology, sperm count, and that
yes,
is when you do these procedures?
yes. So ICSI is an acronym for something
Hmm.
that is called
Yeah.
intracytoplasmic sperm injection.
Injection, yes.
Intracytoplasmic sperm injection, which means that you are picking up one healthy sperm from the couple of sperms that you see in the sample,
Hmm.
and the embryologist or the scientist is injecting that sperm into the egg. So that procedure, this is an artificial procedure that is carried out in the lab. This is called ICSI or intracytoplasmic sperm injection. So if you need only one sperm per egg, if you have 10 eggs, you need only 10 good sperms. So for that is why I said, even if we have a count of less than 1 million, we are not worried because we can still carry out the procedure. Okay, so if the count is very little, so for one egg to be inseminated, we need at least 50,000 normal sperms if we are to do an IVF. But in
Hmm.
case we don't have that many good sperms, then we need to do an ICSI, which is, like I said, we need very few sperms, good sperms. Now, TISA and TESE are the sperm retrieval techniques. If you're retrieving it from something called the head of the testes, which is the epididymis, then it is TESE. And when it is retrieved from the testicles, then it is TISA. So
TISA, okay.
basically, it's just an aspiration of it's called testicular aspiration. And these are done in cases where we are having obstructive azoospermia, where the sperms are not coming out. In such cases, we sometimes have to resort to this kind of a procedure. There is one indication now, Gayatri, which is coming up, where we do these procedures of testicular aspiration, even when there is no obstruction, and that is when there is a lot of DNA fragmentation of the sperm.
Okay. So
We were
that also
talking
will
of
show up. That should also show up on your semen analysis.
Yes. Those are the
Okay.
tests for semen function, and
Right.
very commonly practiced now. If you do a DNA fragmentation of the sperm, and you find that the sperm DNA fragmentation is very high in a sample, In those patients nowadays, it is, and you give all kinds of treatment to correct it, and yet it is not getting corrected. Then, in those cases, a sperm retrieval from the testes is advocated because it's known to give better results. The
Okay.
DNA is said to get fragmented when it comes out through the passage. So,
Right.
therefore, you resort to
So,
this.
are there any congenital conditions that can be the cause of male infertility? And if there are, what are the tests that can be done to diagnose this condition?
Genetics plays a lot of this thing in male infertility as well as we have in female, and one of the common conditions is when we have the Y chromosome not being present. It is called Y chromosome deletion, and
Okay.
that is found in patients where when you see a sperm sample and you find that it is a very poor semen sample. Like I said, you have everything abnormal, the count is abnormal, the quality is very bad. In those patients where before you want to do any of these procedures that we are talking about, we should try and see whether there is any genetic problem in those patients, because if there is a Y deletion, there are chances that the same condition might be passed on to the progeny. And
Okay.
if it is a boy, so the condition can be inherited. Or sometimes it also tells us whether we will actually be finding any sperms in the sample or not. That is technical, and I think we should leave that part because that is
For
something
another time. Yes.
for
Yes.
another time.
Yeah.
But
Yeah.
this test does tell us these things, that whether we are going to be successful or not. So
So,
this
so,
is one test which we should be doing. Yeah.
so tests are available,
Yes,
and
yes,
we can, and they can. If there's somebody who's interested, they can get in touch with you directly.
yes, yes.
Um, and I can see that we are running out of time. We've already been chatting with each other for 50 minutes. So, so I am going to summarize now. And,
Okay.
the some of the takeaways that, you have, from what I have understood is that despite the huge population in our country, reproduction remains a personal choice. And I think it's only fair for people who want to have children and they're unable to, for them to, seek advice from people like yourselves. The second is that it's relatively safe to undergo IVF um, treatment right now, despite the coronavirus pandemic. Um, the couple should be, go to a proper center and get themselves tested by reliable labs, and they should feel secure enough to undergo or start the IVF treatment. And the third one is that as of now, no third party reproduction. So, don't use donors, sperm donors, or oocyte egg donors. Wait for a while if you need to use that. And unless you can be absolutely sure that the donors have, no other health issues and they've been tested properly. Um, so would you like to add to that, Dr. Malik, or can I just now conclude? And
Think you have practically said everything except
Mhm.
that the male part. All I can say is that the men shouldn't be disheartened. There's a
Right,
lot
right,
of help available for the male part as well. Male infertility was a no-no for many years till now, but now it is opening up, and we are trying to discover the reasons for male infertility, not only the treatment but the reasons as well. And definitely there's a lot of treatment available for male infertility as well. So therefore, and they must also always remember that the results are much better than female infertility, because remember that in the female there is the egg as well as the uterus, two components. Here we have only the sperm to tackle. So therefore they should not get disheartened, and that should also be a very, very promising kind of a treatment for them. So
right,
that is
right.
all that I would like to add to what you have already said. Yeah.
So I'd like to conclude by thanking Dr. Sonia Malik for addressing infertility in general and specifically in areas related to male infertility, for giving clarity to so many misconceptions and answering, the questions that I was asking her. There are a whole host of questions which have come from the public. So to get in touch with Dr. Sonia Malik, please contact Health Travelers Worldwide team. Health Travelers services include medical assistance and rescue, medical travel, second opinions, teleconsultations, surgeries abroad, and medical training. We thank Nat Health, Healthcare Federation of India, for lending their support to the program. Should you have any further questions, please write to us. Please like, share, follow, subscribe to the Health Travelers page on Facebook, Instagram, LinkedIn, and YouTube for updates and helpful medical information. I look forward to you joining me with my next guest speaker, Dr. Naveen Sakuja, well-known ophthalmic surgeon, on Saturday, the 11th of July, 2020. Goodbye. Have a good day.
Thank you very much, Gayatri, once again, and thank you, Health Travelers, for having me here. I really enjoyed this session. Thank you so much.
Thank you, Sonia. Thanks again.
Thank you.
Bye.